The nurses initially were very hesitant about the multidisciplinary rounds because they've had bad experiences in the past where physicians wouldn't show up for multidisciplinary rounds. And they felt that also between 9 and 9:40 was one of the busiest time of the day for them in terms of dispensing of medication and patient care. But once they realized that the pilot started, that all the physicians were attending these multidisciplinary rounds and they were asking for the nurses to get feedback from them, the word quickly got around that this process was taken very seriously by the hospitalists, and then there was a rapid buy-in. Secondly, there were also, just as there are a subset of physicians that don't want to interact with nurses, there are a certain subset of nurses that actually don't want to interact with physicians. And these nurses rapidly became dissatisfied with this type of process, and they asked to be transferred, or they eventually retired. And we were able to replace them with nurses that were very enthusiastic about physician interaction. Because of the decreased average length of stay and improved throughput for the entire floor, this increased nursing burden, because their productivity is measured differently, sometimes on an overnight, midnight census, which doesn't truly capture the turnover rate that decreasing an average length of stay on a floor with backfill produces. So we learned a lot of very valuable lessons about how improving a process, such as lowering average length of stay and increasing throughput, can put a stress on an entirely different department, such as nursing.